welcome you to the Drug Policy Committee hearing. They gave me this thing, I may as well use it. So good to see all of you here. I appreciate all of you coming in the midst of a hot summer. Some of you are in the midst of a hot campaign, and to take a few moments to talk about this issue. This was something that came up back in January. I filed a bill, House Bill 1316. You have it in front of you. There are also basically a breakdown of House Bill 1316 that Mary Catherine Sperry put together. And also in front of you is an agenda for the day. And just for a couple of housekeeping matters, the 3:15 time slot, there's no one that's going to present there. The 3:45 time slot is not here and not coming, and the 4 o'clock is not coming. So we are going to get through about 3:45. I'll make my closing remarks. We will take a break at 2:45 for 15 minutes, so you can look forward to that if you need to. Okay, so this is an issue involving white bagging, brown bagging, and the cost of prescription drugs. It's an issue that I wanted to know more about, because this particular bill would have required the state health plan and Medicaid and managed care to do some things differently when it comes to prescription drugs. And so today we're going to be hearing from folks from all sides of this issue, and we will have some time between now and January to continue the conversation about whether or not we want to go forward with this bill or not. So our first presenter of the day is Mr. Todd Deere from the Mississippi Board of Pharmacy. Mr. Deere, we're glad that you're here, and I will turn it over to you.
Thank you, Chairman Yancey. My name is Todd Deere. I'm the Associate Director at the Board of Pharmacy. I just want to start by saying thank you to everybody in attendance, specifically Chairman Yancey, members of this drug policy group, representatives if they're here for the speaker pro tem delegation. I see Department of Insurance, State Health Plan, and everyone else has come out. I just want to say thanks for the opportunity to educate and to share some of our thoughts on this from the Board of Pharmacy's perspective. Next slide, please, or I've got it. So, kind of a highlight, I didn't want to have a breakout in front of you. I wanted just to find a couple topics and kind of explain what we're talking about with clinician-administered drugs, and then different bagging pathways that you'll hear referenced throughout this hearing. I want to specifically focus on white bagging, because that is the most prevalent of the pathways and some potential safety concerns and impact on the medication distribution process. And then also kind of take a look at the national landscape around this practice.
Let me interrupt you very quickly. Just assume we don't know anything and explain to us what white bagging is and brown bagging. And speak into your microphone. Thank you.
All right. Can y'all hear me better now?
There's a button on it.
I'm not AV, but I'm teachable. So this sounds a little better, I hope. If you don't like the sound of my voice, I can't do much about that. Clinician-administered drugs. So basically, this is a drug that's going to be administered in the outpatient setting, and it's something that the patient, even with good training, can't be taught to give themselves. A provider has to give it to them. Typically, you're thinking about an IV therapy that requires specialized care for administration. Often these are for serious or rare conditions. We're looking at things like cancer, multiple sclerosis, rheumatoid arthritis. In some cases with cancer it's curative, and so it's completely life-changing. In other cases it can be the difference in someone being able to go to the bathroom by themselves and lift up their toilet seat. And so when they can't get access to these medications, it can have a profound impact on their lives. Traditionally in the space, whoever the provider has been purchases the medication and then bills it out on a medical claim. It's called buy and bill in the industry. It's what you'll hear. With these drugs, there are complex storage and handling requirements that have to be taken into consideration. The USP, which is the United States Pharmacopoeia, generally says for just medications in general that the temperature storage range is 59 to 86 degrees Fahrenheit. when you look on the label of many of the medications, it's actually more narrow, and it says 68 to 77 degrees Fahrenheit. And if you have temperature excursions, then they want you to call or look at the literature to see, hey, is this still going to be effective? Has an excursion made this product adulterated? But with these, typically most of these require refrigerated or even more intense storage, so it's even more than that. So I'm happy to answer any questions, but I've got a couple for you guys too. Did anybody see in the news yesterday what happened in Phoenix? They set a record. Anybody want to? Temperature excursions up to 110 degrees, 19 straight days of the temperature hitting 110 Fahrenheit at Phoenix. That caught my attention for a couple of reasons. That's hot, and I'm thankful it's not that hot here, but there's also many facilities located in the Phoenix metro area that send these type of medications into Mississippi. I've personally been in some of them. So, my question is, this is something that can be concerning when you have temp excursions, let alone thinking about it getting to Mississippi, and it is hot out there today. And if any point people have questions, feel free, I'll address them or I'll address them at the end. So what's the big or the bag problem? So kind of trying to break down all these different bag acronyms we throw out. How I remember it, brown bag is kind of like a brown bag lunch. You bring it with you. So the patient gets it in the mail typically, or they may have to go sometimes a long ways out of their way to a special pharmacy and pick it up. Maybe it's their home pharmacy, but regardless, somehow the patient takes possession of the medication. And just like when you're bringing your lunch to work, they're brown bagging it to where the provider is going to give it to them. There's a lot of concerns with this, as you can imagine. That can really overwhelm the patient at some points, especially with some of the storage requirements. And unfortunately with us, we have patients in Mississippi that don't have access to steady house, electricity, all these type of things that, if that's mandated, could really be a big issue and impact patients' care. I'm not going to spend a lot of time on brown bagging because it is more limited. You do see it sometimes, and maybe there's a good role for it when patients are getting things infused at home via a home health provider. There may be a good situation for that. Yes, Chairman Yancey.
Let me just jump in here and say, if a patient had cancer and they were prescribed a chemo IV drug, and so what we're talking about is, rather than you going to a place and having your treatment and that chemo drug being provided by the pharmacy at that place, white bagging is, the way that I understand it, is this chemo drug would be at a pharmacy somewhere else, and it would be sent through the mail to the place where you're going to have your treatment, or to your house, or wherever it is you're having your treatment. And it's called white bagging because it's almost like it's a pharmacy white bag that's stapled, and the patient never touches it. It just gets shipped to where it's going. Okay, that's what's kind of currently happening.
And I would agree with that completely. I'd always kind of assumed that's what white bagging meant, but in getting ready for this, I actually learned something. Okay. Brown bagging, patient gets it, and they get it to the provider. White bagging, the actual background of that, because I always thought white glove service or a white bag, delivery, is actually because it's being delivered to the people that wear the white coats, so the providers. And so that was something I didn't know before last week, to be honest with you. But it's coming through the mail always with a white bagging situation, and it's going to the provider. And then there's this term called clear bagging, and that is when a hospital system or a provider system have their own pharmacy, and they run it through the pharmacy prescription claim, and then send it over there to the provider's clinician's office for it to be administered. But all of these pathways, instead of it being billed through the medical benefit of the patient, is being billed through their pharmacy benefits. And sometimes that's not better for the patient financially. I mean, I know that's not the gist of this hearing, but it has impacts downstream. Any questions on the bagging as a whole?
Is there any cost difference to the patient, whether they get the drug from outside versus inside? I mean, does the insurance cover exactly the same amount both places, or is it less?
So For a particular patient, it should be pretty similar typically if they're getting it through, if it's being billed medically. If it's being billed on the pharmacy benefits, there could be incentives to use a preferred pharmacy. And so it's really going to depend on that patient's plan. And also, there could be big differences depending on if they have a cost share with their medical plan or their pharmacy plan. It is just so dependent on that individual patient. I can't answer that globally, but it's something that you've got to be aware of, that it's going to have an impact somehow.
Representative Eubanks?
Thank you, Mr. Chairman. So am I understanding it correctly that when typically if they're white bagging it, it's going to the facility or the physician that's going to administer it, they don't do any kind of markup or anything, do they? A handling fee or, so it's actually, it would actually be cheaper if the patient brought it with them, brown bagged it, as opposed to white bagged it?
So the question is, in white bagging, is there a markup from the facility on handling that? And I know there's some people here that represent that more than I do, but I will tell you what they get to bill from the facility level when it's white bagged or brown bagged, they get to bill the administration fee, nothing more. So for the facility and the patient, on their medical bill from getting it administered, whether it's white bagged or brown bagged or clear bagged, the only thing they're going to get charged for the facility is the administration fee.
Okay.
I'm getting a lot of looks. I think people are confused. I'm not sure what the clear bagging is, but so this bill would basically ban brown bagging, which is giving it to the patient to take to the place where they're going to be treated. Not every single patient is probably responsible enough to keep up with their medicine or not leave it in the car overnight or whatever. So this bans that. This bill gives an option other than white bagging. And that option is for the medicine to be bought from the place where you are being treated. Okay, so it's already there. Okay, and so what is, say again what clear bagging is?
It's a cousin of white bagging. Instead of it being an external pharmacy that's running the claim, it's an internal one to the provider. So very similar to white bagging. It's just there's not an external player involved in that. And all things together, what this bill does, from my understanding, it makes it to where this can't be required. One of these pathways cannot be required. It may be an option, but not required.
So I think what the issue is that you have plans that are steering patients toward where they have to purchase their prescriptions. And this gives a patient more options as to where they purchase their prescription on these difficult to self-administer prescriptions like IV drugs for cancer, etc.
Agreed.
Representative Curry.
Thank you. So I didn't know there was a problem. And I think that if you're looking at banning something, this is going to be mainly, my assumption would be Medicare patients with Humana or United or whatever. You have Medicare, and then you have to buy a supplement, and then all of a sudden all of your medicines come from the supplement. And so when you start down that road, that patient pays pretty much zero for that medicine with their supplement. Are we getting into forcing them to pay more or a copay somewhere else because we care what color the bag is?
Representative Curry, is that correct?
That's correct.
So basically the comment is, are we creating unintended consequences by banning? I would state again, my understanding that this bill just doesn't allow it to be mandated. If the provider and the patient decide that this is a process that they want to go down, my understanding of reading the bill is it's still allowed. It just doesn't allow the payer to say, this is how you're going to get it. And that is what I would recommend from my perspective.
But they already do. They already do tell you where you're going to get it if you're on one of those plans.
Well, and if there's a cost perspective that you don't want to, encumber, then you could say that I'm fine doing that. I don't think this bill takes that pathway away.
I'm not understanding if we all know in here, when you say shall, that means you shall do it.
The bill
But if the bill says may, it's not worth the paper it's written on. I'm just throwing that out there.
The bill prohibits a second copay from being charged or any additional fee from being charged.
Okay.
Representative Scoggin.
If I understood you correctly, you're saying that under this bill, brown bagging will become illegal.
That's my understanding. And if you look at your summary of your bill, which is a one-pager front and back,
Let me give you a scenario and tell me if I'm even on the right track or I'm out in left field. If, as a provider, I've got a patient that comes in for, say it's a female and they need hormone replacement. If I give them something that I've got in the clinic, that's all good and well, but maybe they can't take whatever the branded product is, and they have to go to a compounding pharmacy, pick up the hormones that have been compounded from a pharmacy. The pharmacy gives them the injectable vial. They bring it back to the clinic. I give them that compounded hormone. You're telling me that under this bill, that is illegal?
that may be what it means. I'm not sure.
Or methotrexate.
I would encourage conversation regarding this. I think it's great points from my point of view. When I look at this, and this is based off the model language from a national organization, it says the health benefit plan shall not require. So to me, I read that as they can't mandate it, but it doesn't mean it can't be an option. I think that's the intent of the national language that was used for this, but I think it's definitely something for the committee to consider. I think there's instances, and it'll be in the presentation later, to where I feel like there are limited times to where that type of process is needed.
All right, any other questions for Mr. Deere?
All right, I'm going to advance if there's no other questions. I do have a pop-up on the slide if someone can help me. And I'm unable to advance the slides at this point. Awesome. So potential issues with payer mandated white bagging. I'm going to focus primarily on the safety aspects and access perspectives, but there are 4 buckets you'll see most of the concerns kind of go around. It's unsafe, it limits access and patient choice, can create delays in therapy, and it can be wasteful. So getting to why it's unsafe, we've already kind of touched on delivery, transit, storage, integrity concerns. Not only do you have issues with it traveling through the mail, and last time I checked, mail trucks aren't refrigerated. If there's delays, once it arrives at the patient's house, if they're home and able to bring it in immediately, or maybe they're on vacation or working the night shift and it stays out on the front porch for an extended period of time, there's a lot of concerns around that. It also circumvents federal track trace requirements and assurances that are typically provided or required when you order a medication as a dispensing provider or pharmacy. These medications also arrive to the provider, ultimately however they get there, and they're not really ready to administer to the patient typically. Most of these drugs require compounding or further manipulation that requires special facilities or aseptic technique, etc. And so in addition to the receiving pharmacy being asked to compound something that they really don't have full assurance of where it came from and how it's been stored, and if it's still going to be effective, having the chain of custody's perspective, they're also asked to manipulate a drug that's already dispensed and has a patient label on it. And we'll talk about that, some of the concerns around that as well in this presentation. The other safety concerns in a consolidated provision of care at the provider's office, orders about the patient's, clinical parameters and their therapies all entered into the electronic health record, and there is a comprehensive safety check that occurs. When you're entering things in and running them in through different systems, you lose a lot of that safety that may flag. The other thing, and this is particularly concerning, in my opinion, in patients that are undergoing cancer care, you're unable to quickly accommodate changes in patient conditions and treatment plans. I hope none of you have had family members that have been affected by cancer, but if you have, you know that unfortunately every time you go to get your therapy, you have the whole lab dread to make sure, are my numbers high enough? Can I get my full dose? Am I going to get my dose at all? Are they going to have to change my therapy? And this would create additional delays from that perspective of if the product that's been shipped in is unable to accommodate the current condition of the patient.
We've allotted about 15 minutes for every speaker. We've gone over a little bit because I took up part of Mr. Deere's time at the beginning, and we've asked him a lot of questions. I just want to say I'm a little bit more clear on what Representative Scoggin and Representative Curry were asking. The bill doesn't ban anything. It just doesn't require the insurance company to require brown bagging or white bagging. It gives an option, okay? It gives an option to do it another way, for the patient to do it another way. All right. Mr. Deere, does anyone else have a question for him? And then we will let him get off the hot seat. All right. Thank you so much for being here today. I appreciate you coming. Our next presenter is Mr. Alex Quisenberry, or I should say Dr. PharmD, Director of Pharmacy for Baptist Cancer Center and Baptist Clinical Research Institute. So,
Hi, good afternoon, and great pronunciation on my last name. That's you nailed it. So, as he said, I'm Alex Quessenberry. I'm the Pharmacy Director for Baptist Cancer Center, headquartered out of Memphis, Tennessee. I made that long drive today, but also representing our 7 locations that are throughout the Mississippi areas. We have cancer centers as part of the Baptist Memorial Healthcare umbrella in South Haven, Oxford, New Albany, Grenada, Golden Triangle, Starkville, and as well here in Jackson, Mississippi. So I'll go through and touch on a few of the same points that Dr. Deere made, and as well go through a few new things that he did not cover or have the time to cover. So I do want to talk about, I think we've hit enough on the definitions, but review over the vertical integration in healthcare, the reason why we're having this new practice of white bagging. We'll talk about really the challenges in the daily workflow that this requires on our staff. Talk about a couple of the specific insurance companies and their requirements, and then really talk about the impact on both the providers, the facilities, and then as well as those patients. All right, so I think we've nailed down the definitions well enough. I did, though, want to hit on 2 others. Again, buy and bill. That's when we're in the outpatient infusion setting, like I am. We're administering chemotherapies. Traditionally, we buy the medication from the wholesalers, and then we infuse it and we bill it on behalf of the medical benefit. The other definition we didn't get to spend a lot of time on that you're seeing brought out is alternative sites of care. So this is where the insurance mandate that this treatment cannot be done in a hospital facility. It needs to be done in a clinic, in a physician-owned practice. And so it really does dictate where that patient can actually receive their care. And I'll get into some of those specifics. So this has been brewing for the past few decades. I mean, back in 1998, when you started having these large insurance companies start purchasing their own PBMs and then purchasing their own specialty pharmacies that could eventually dispense this. So UHC, they started down that road in 1998. Prime Therapeutics started incorporating this in those Blue Cross Blue Shield plans back in 2000. UHC then acquired Optum, which is another specialty pharmacy, about a decade ago. And then lastly here, most recently, within the past 5 years, the CVS Caremark merger happened, and then the Cigna acquired Express Scripts. So I've kind of laid out on this slide talking about here's the overarching insurance company, here is their PBMs that they own, and then here's their individual specialty pharmacies. So by doing white bagging, they're keeping all of the potential revenue in-house, and they're dispensing from that to the individual infusion group. So, as I said earlier, when we talk about a buy and bill, a traditional way that we purchased and bill for those treatments in our infusion settings, we contact the insurance company, we get a prior authorization, we get the approval to say, okay, yes, this can be done in our facility. We purchase the medication from our wholesaler, it comes in, we compound it and infuse it. We now have to add in a couple of more steps when we have to white bag a prescription product. Fortunately, we're told on the front end, most of the time, that this drug is now required to go through a specialty pharmacy. Now the back and forth communication starts, so now we have to send a prescription to that specialty pharmacy. That specialty pharmacy then has to contact the patient directly. And as you can imagine, patients with cancer are going through many different providers, many different communications between what bills they have to pay. Well, now they've been told, hi, I'm so-and-so with the specialty pharmacy, you need to pay your copay. That can be pretty high before that we can even begin your treatments. If they're able to pay it, which sometimes they're not, then that prescription will then be, of course, mailed to the infusion office. We'll infuse it. We'll charge a $0 fee for that. And then we have to do that process all over again in the next cycle. So this is a repeating process. As we mentioned, the clear bagging, I know that was a little bit of confusion before. At Baptist Memorial Healthcare, we actually have our own specialty pharmacy. So fortunately, we can send a prescription through our own electronic medical record, and then we can transfer it, even walk it by hand. So we know the chain of custody, that cold chain, to ensure that product was kept at the appropriate temperatures. Now, talking about a couple of the insurance companies that we deal with and some of the challenges, I'll go through Aetna. I'll talk to you guys too about Blue Cross Blue Shield of Tennessee, although I realize this is Mississippi, but we do have South Haven patients too to consider. Cigna, and then United Healthcare. So we discussed or I brought up the site of care challenges. So Aetna has been one of those back in, all this occurred during the midst of COVID. So they started a site of care management program, and really they focused on some of the most common drugs that we give in oncology, those being Keytruda, Opdivo. You may have seen commercials for those, but those products are they're biologics, they're immunotherapy, and they really can treat a wide variety of cancer types. So now they have stated that hospital outpatient infusion centers are not allowed to infuse these types of treatments, and then they force these patients to go see somebody outside of their personal doctor. Now, the one most troubling, and I really want to bring this to everyone's attention. So previously, we're only talking a handful of medications, but when you look at what Blue Cross Blue Shield of Tennessee's done, they have gone through the gamut and included 320 different medications that now have to come through a specialty pharmacy. This is pretty much every patient for Blue Cross Blue Shield of Tennessee that we treat now all has to go through that entire process and steps, and as you can imagine, that builds and builds upon the amount of work and effort across for everybody. Cigna as well, they have specific criteria for those site of care restrictions. This is their list of medications. Again, these are some of the most common biologics that we see, drugs like Opdivo, Neulasta, Herceptin, Avastin, and again, these are across a wide variety of cancer types. I really feel that just almost about everybody is covered. And then lastly, United Healthcare, they have also implemented a specialty process for, here's 5 of their medications that they felt that were required to go through a specialty. Okay, let's talk about some of the impact. Again, that's a lot about the policy, but what does it really look like for providers and institutions? Well, look, there's a huge financial impact. Providers are no longer able to bill for these medications. As we said, we're only able to bill for the actual infusion that's provided, which is minimal compared to the medications. We're not allowed any reimbursement for the preparation supplies, any compounding, even sometimes the IV bags, the tubing, the gowns that we have to use. We already talked a little bit about the legal risk and this breaking in the chain of custody and the challenges as we have these heat waves across the country. That's the worst. You can imagine medication that's sitting on somebody's front porch and never gets put in the refrigeration. Or also you could think about patients that do get these things brown bagged and then they get potentially a chemotherapy agent that they're just putting in the refrigerator next to their milk and eggs. As you can imagine, that really irritates me and worries me as a pharmacist. Well, and then when we talk about ultimately, yes, our pharmacists, our providers are responsible for the treatments that are given, and also responsible for ensuring that these products are going to meet the expected outcomes. And if they've been spoiled, that's not going to be the case. Did also want to make mention that the challenges when it comes to storage. When we have a buy and bill practice, everything's on the shelf. We'll pull whichever vial, the correct vial. But when it comes to specialty, all of these drugs are now have a patient label on it. This is the specific medication that I have to use on Ms. Smith, or this is the one I got to use on Mr. Jones. And keeping up with that can be quite a challenge. So when we talk, and then of course the extra time and effort that our staff have to go through to do this. So, but you guys want to hear, what does it impact on our patients, right? This does have a negative impact on patients, and I've got a couple of examples after this slide. But ultimately, this really does delay therapy, and as you can imagine with cancer patients, any delay can potentially, prevent cure, and it can potentially enable the cancer to progress. And those delays not only come from just that coordination, but ensuring that the patients pay their copay, that they have that money sit in the bank. Because a lot of times we're collecting a payment, well after the treatment has been received. Dr. Deere also mentioned a couple of the challenges when it comes to therapy plans, dose modifications. So, yeah, if you come into the clinic and unfortunately you're met with, hey, you've progressed, now we need to switch therapies to you. Well, whatever you just had received, we can't use that on anybody else. And we can't even return it. That's really part of the waste that comes. We also discussed some of the challenges with our electronic medical records, not being able to understand these multiple prescriptions that are coming in. All right, let's get into these are individual cases that I talked with our pharmacists that work across the infusion clinics in Mississippi. Even down here in Jackson, I heard of a patient who received a brown bag medication, pegfilgrastim, which is used as a blood growth support drug after chemotherapy to make sure that you don't endure febrile neutropenia, put yourself at a risk of infection after in chemotherapy. It is a shot. It's a subcutaneous shot. But they received this medication in a Walmart parking lot. I was surprised to hear it. Zero counseling, just, hey, they communicated, said, hey, where can you meet me? I have your medication to pick up. I thought that was about as shady as could be. The next example I want to tell you about is a patient, I think this was down in South Haven. So this patient was prescribed Darzalex or daratumumab. This is a treatment for multiple myeloma. They had to pay a substantial amount of out-of-pocket before they could ever even receive the medication. So it was dispensed through our specialty pharmacy. But unfortunately, before the patient was able to receive their treatment, they had to be hospitalized and unfortunately later passed away during that hospitalization. The widow of that patient reached out to our specialty pharmacy, as you can imagine, quite worried about her finances and quite worried that she just had to pay $1,100 out of pocket. Well, she was obviously looking for a refund. I mean, the patient never received this treatment, and it wasn't fair to her that she had to be on the hook for a treatment that was never provided. Eventually, we were able to process a refund with the manufacturer's support. I mean, we had to go direct to the company. But it took 20 hours of a pharmacist's time just of coordination and back and forth and constant phone calls to get this done.
Let's pause right there, Dr. Quisenberry. Are there any questions from any members of the committees that are here? Okay, for the sake of time, I'm going to let you make a closing statement of what you believe about this bill and what we need to know, and I appreciate you being here today, and I appreciate your expertise.
Thank you so much. Yeah, again, just there may be opportunities when the white bagging process might work for a certain physician, but it should never be mandated across the board. As we talked about, all the potential delays, the potential additional costs that are unforeseen, and just the extra burden that occurs for it all. So I, again, appreciate all your time. And
I think Representative Sanders has a question.
Yes.
You're recognized.
Thank you, Mr. Chairman. I think you really highlighted some of the questions I had. I'm concerned about the challenges. How do we go about remedying these challenges? What's the solution? Because there are some things going to come up from constituents of mine, and I'm just wanting to be able to explain some of the things that, that I've been told today, and I want to make sure I'm explaining it right. So I just want to know what are we going to do? How are we going to handle some of those challenges?
well, I mean, if we enact this bill and do not force and require all these patients to be sent through this process, that will really truly be the solution. I know many states have enacted such a similar bill. I think this is, I mean, Dr. Deere, how many different states now have enacted?
Louisiana and Tennessee and Arkansas are the closest to us.
Yeah, this is across the country, and thankfully this was, a lot of the language in this bill came from our ASHP, our American Society of Health System Pharmacists. So nationally, this is what we're all as pharmacists trying to get past.
All right. There are no other questions. Thank you very much, Dr. Quisenberry. Thank you for being here with us. Our next speaker is Brad Summers from UMMC, Executive Director of Pharmacy Services. You have the floor.
Thank you, sir. Can everybody hear me okay? Sometimes it's kind of hard to judge when you're talking to the microphone, so let me get my slides up real quick. Brad Summers, Executive Director of Pharmacy at the University of Mississippi Medical Center. Mr. Yancey, committee members, greatly appreciate the opportunity to talk with you all today about this very important subject. I'm actually going to probably adapt a little bit on the fly as we go through this based upon what my two previous colleagues have discussed, and maybe work the slides a little bit differently here. So those are not mine. I'm Summers. Sir, you asked a question a minute ago, and I want to follow up to that question as well, just real quick, and this is going to be on one of my slides. Part of the issue right now, or the challenge right now, is that in this entire process, the patient nor a clinical advisor on the treatment team has any say-so in where the product is coming from. That's what needs to be fixed. And that's what this bill allows to do as it removes from the requirements around that. There is no say-so from a patient perspective or from a provider perspective or a treatment team perspective of where that medication is coming from. And so that's a big challenge. That's actually one of the, let's see if we can go there real quick. I'm going to jump straight to the patient care side of things. So 4 things I want to talk about today: the impact on the health system, the impact on patient care. I'm going to provide some specific examples from my perspective that we've seen from a patient care perspective. And then I actually have some primary data survey that I want to circle back around to just give you guys some real numbers as it relates to that. So I'm going to jump straight to the patient side of things. So safety and quality is a big concern here. The first thing being, anytime you work outside of a system's processes and procedures, you're increasing your risk for an error. Every system is set up to try to reduce that from occurring. If you go outside the circle, if you open the circle up and go outside that process, you're increasing your risk for a mistake. So specifically here, anytime we work outside of our electronic health record, you're going to increase the risk of missing something. You're going to increase the risk of missing a significant drug interaction. You're going to increase the risk of potentially missing a significant adverse effect that can impact a patient. The second point there was talking about the patients and their inability to be able to utilize their preferred pharmacy. So in most of the time in these scenarios, a particular white bagging pharmacy is going to be chosen by the payer. And typically that's probably not going to be the same pharmacy that typically a patient is normally utilizing as their home pharmacy. Delays in treatment, shipment, and shipping access. So we talked a little bit about shipping. Dr. Quisenberry spoke in regards to delays in shipping and getting the treatment and lost therapies, things of that nature. Access is another big component. This was also asked a moment ago, and I want to give an example of a Medicare patient. So say you have a Medicare patient who has a Part B supplement that can cover the medical infusion side. They also have a Part D plan. And say the insurance company is requiring it to go through a white bagging process, so it has to be processed through a Part D plan. There is a high likelihood, because of the cost of these therapies, that patient immediately is going to hit the donut hole. You have all heard the donut hole, basically, where you have to get through that out-of-pocket cost before you hit the catastrophic coverage. They're going to hit that immediately with these treatments and have to come up with that cost before the shipment is going to be sent to the patient. On the flip side, from an infusion, from a Medicare medical billing perspective, a patient may have a supplement where it's completely covered across the board. So I think it's just a good point to bring up from an access perspective. It's something to take into consideration. The fourth item on this list associates back to a dose adjustment. We talked a little bit about this from a treatment plan perspective. I'm going to give you guys an example here. So as Dr. Deere mentioned earlier, it's not uncommon for a chemotherapeutic regimen for a patient to need labs the day they're getting the treatment, If you're going to go through a white bagging process, you got to have that medication there the day of the treatment. Say the patient's getting 600 milligrams, a 500 milligram vial, 100 milligram vial. Say those labs come back the day of, and maybe their renal function is out of whack, or their liver function is out of whack, or their white blood cell count's too low. Well, you have to make an adjustment on the fly. If we're able to do buy and bill, I can literally take that extra 100 milligram vial, stick it back on my shelf. There's no waste associated with that. In this situation, we have an extra 100 milligram vial that a patient will never receive. We can't use it for anybody else. So there's a waste component associated with this as well. On the flip side, say that white bagging pharmacy is doing their job, they're seeing those treatments, and say 2 months later, you check labs day of, and now, hey, their function looks a lot better. They need that 600 milligrams. Well, now you're going to have to completely stop the show. You're going to have to get with the white bagging pharmacy. You're going to have to delay the therapy, get the patient rescheduled, because I can't just grab that extra 100 milligram vial off my shelf. Let's talk about some patient-specific scenarios that I've seen at UMMC. The first one, I want to circle back to what I mentioned a minute ago about processes and procedures and the risk of an error as a result of going outside your standardized processes. So cytarabine is a cancer treatment. We were required to white bag this particular therapy from a white bagging pharmacy. We ordered the concentration of the product that we ordered. There's two concentrations of this. The concentration of the product that we ordered was not sent to us. They actually sent the more concentrated version. Luckily, we had a very astute pharmacist that was able to determine, hey, this is the more concentrated version. Had we give that patient the intended dose, they would have been overdosed. Obviously, the biggest concern there is the impact to the patient, but there's also a cost associated with that. That patient probably would have required extra care, potential hospitalization as well, associated with that. On the other side of it, not only do we have a situation where a med error occurred, but now we also have a situation where we have extra volume that's being wasted because the wrong concentration was sent to us. There's also a statistic I saw from the Academy of Managed Care Pharmacy. There's an estimated impact in the healthcare system for morbidity and mortality associated with medication errors. What I'm talking about here, $77 billion a year. So there's big money, big concern associated with Med-Airs. Ocrevus, the next drug, as an example, used for multiple sclerosis. This is about a $20,000 to $30,000 a dose treatment. For this particular situation, the white bagging pharmacy would not allow the provider or our health system pharmacy to help coordinate and get the medication from the pharmacy to our health system. They were requiring the patient to take care of all this. It's very overwhelming for a patient to try to coordinate that entire process while they're also trying to manage their current disease state. In this particular situation, it led to weeks of a delay as far as getting the patient their scheduled dose. And the last one, Privigen, is also very expensive medication. It's an IVIG therapy. In this particular case, this patient was receiving 25 grams of this every 2 weeks. To give you some perspective, we're talking thousands of dollars per dose every 2 weeks. So it's not uncommon in these situations where a dose needs to be held from a treatment perspective or a patient's out of town. Well, the white bagging pharmacy is doing what they're supposed to do. They're shipping that drug every 2 weeks. Because of the break in the circle, the break in communication, now you have a bunch of extra doses that you cannot utilize that ultimately have to be wasted. On the flip side of that, also, the same exact patient had the same situation where they were having to coordinate the entire process, which was leading to delay. So you have a situation, one, where they're skipping doses on purpose, and there's leading to waste. The second part of this, you actually have a situation where the drug is needed, but the coordination, because it's being held up to the patient to take care of, is actually leading to a delay to actually get back to the pharmacy so it can be administered to that particular patient. So you can see there's significant concerns here, and these are real life situations that have happened to real patients that we're currently seeing, at UMMC. I did want to circle back around with some primary literature here. This was a survey that was conducted back in 2021. There was 268 different groups that were involved in this survey. It occurred from a group called Vizient, which is a healthcare performance improvement company. This is associated with 50% of the health systems and hospitals. And so I think this kind of hits home some of those items I just spoke on, which you've heard previously in this discussion. So first, costs. And these are just operational costs, estimated operational costs, and estimated labor resources. $415 million extra just for those things to support white bagging. Notice that 95% of these respondents have not even been able to quantify the waste component. So that example I gave earlier about not needing the 100 milligram vial, that is not even taken into consideration of what that number looks like for that $415 million. I'm sure it's far more significant. 92% experienced patient care issues due to practice. You've heard these things. 83%, the product did not arrive on time. 66% report that the product delivered no longer had the correct or updated treatment plan course or dose change like we talked about previously. 42% the product delivered was inappropriate or the wrong dose, talking about the Med-Air I mentioned to you guys a moment ago. And then 95% experienced pharmacy operational issues. So there's the components on here in regards to the management system, inventory management system, security concerns, space for storage. I want to focus though on the barcode situation. Barcoding is so important from a treatment perspective and from a hospital perspective. It basically allows us to ensure, number one, the patient's getting the correct drug at the correct time. It also protects the employees, the nurses, the pharmacy staff, et cetera, to ensure what they're doing is accurate. Everything that we do within this model is set up based upon the drugs that we get from our distributor on a regular basis. We have this completely set up. If you're getting medications outside of that cycle, there's a good chance that those are not going to work correctly from a barcode scanning perspective. It puts the patient at risk. It puts the facility at risk from a liability perspective.
Let me stop you right there. Are there any questions from any members of the committee? Representative Curry?
Thank you, sir.
Recognized.
And you don't know me very well, but I want to do everything I can to help my hospitals. And I do not like a PBM. I'm trying to figure out where we want to go here. And I've been a home health nurse for a long time. I've never one time given a chemotherapy drug in the home, ever. Is there any that you know of that are given in the home? Because I don't know of any.
I don't work in the home health sector. From UMMC perspective, we don't have a home health practice, as it relates to that. But I will also mention that,
35 years I've done it, never. And so the reason I'm saying to you, I'm trying to figure out where this is going, you know. Is it that we are trying to protect the hospitals giving infusion? I agree, a Part B needs to go and have everything paid for in that facility. That's better for the hospitals, probably better for the patient. But I'm not exactly sure where you're trying to go. I'm trying to figure it out with this bill, and I can't.
Based upon my interpretation of the bill, I think the way I read the bill is it basically removes mandated requirements that are generated from the insurance company to lead patients a certain direction. It basically allows the choice to come back and play. And that was kind of the big point I made at the beginning of this. Right now, there's literally no choice from a patient perspective or from a provider perspective. Whenever these insurance companies make these mandates, there's no control whatsoever. It's like, hey, do you want your treatment? Do you want your treatment paid for? Well, this is the way it has to occur. That's literally what needs to be addressed. And I think what this bill is trying to address is to
Because I
produce
think
that
we're going
flexibility.
a lot of different ways, but we need to get to where people are understanding it. You know, we talked about somebody needing a refund. You know, if you buy that medicine, that's your medicine. You know that as well as I do. It's like, well, I went and bought groceries, but my husband died and couldn't eat it. Can I get a refund for the groceries? Those things just aren't going to happen. Medicine errors happen, unfortunately, they all do. You know, so I want to help my hospitals. I don't like PBMs, but who are we trying to help here? Local
I mean, at the end of the day,
pharmacists?
ultimately,
I'm
no,
asking.
it's the patient at the end of the day. And really the point I'm trying to make with this is that the biggest impact at the end of the day, I can talk to you guys all day about dollars, about, you know, issues from my health center, what I see at UMC, the way I work. At the end of the day, the biggest concern is the patient that's sitting in the chair or sitting in the bed, regardless of where it's located. And really what I'm trying to do is show you guys what we see on a day-to-day basis with these mandated practices that are coming from the payer.
So my daughter had cancer years ago, and she's fine now, but we went to UMC, and she got her therapy there, but I had mailed Neupogen and different things. I'm a registered nurse, sent to me at home, which I was lucky to be that, so I could give her those things as needed. I never asked UMC where they came from. They just arrived in a freezer packing at my door. And, I mean, so it happens a lot, not knowing. I didn't even care where it came from as long as I had it. So I just think we need to be better explaining what we're trying to do.
Thank you.
And this is a very complicated issue and a complicated bill, and that's one of the reasons we're having a hearing on it now. And it's the reason that I didn't bring it out in committee last session, because I didn't understand it either.
Good.
So, all right, Representative Thompson, you're recognized.
I have this question for you. Are we trying to, what I want to know, are we trying to simplify the process for the patient safety? Because you're talking about patient safety and everything. And when you're looking at the pharmacy side of it and you're looking at the billing, if they can't afford it, what are we trying to do on your side? Because the number one thing is you look at the patient safety. Do they understand the clarity of the whole thing and what we're trying to do? Because when you look at a patient, you're going through all these different loops to like prioritization to get for you guys to pay for different things. So how are the patient fit in this when you look at that side of it? What's your recommendations?
Yeah, so, I mean, my recommendation is, and to your point, yes, I mean, with these practices, the way they are set up currently, anytime you have to, and I'm going to circle back around to what I said a minute ago, but it's very important. A circle, you have a circle that you try to keep closed within the health system. Anytime you nick the circle and you deviate outside that circle from a process perspective, there leads to a risk from the health system, but most importantly, there's a risk for patient safety and quality for that particular patient. So yes, trying to streamline that, trying to make it less complex. It's far easier it's far easier and safer that I'm able to utilize my own policies and procedures I've trained my staff on, that they know how to do. They know what to do. It's almost like muscle memory, doing the same thing over and over and over and over and over. The minute you deviate from that is where a risk comes from. When you talk about white bagging coming from thousands of different pharmacies across the country, no telling where they're going to come from. That's where the complexity comes in, and where we as a health system try to figure out how can we do things differently based upon this required practice to ensure, to the best of our ability, even though that circle was nicked, the best of our ability, that a significant issue or an issue in general does not occur. So yes, it's trying to streamline it for the patient from a quality perspective and a safety perspective.
And one final question. Gentleman from Harrison, Representative Felcher, you're recognized.
Thank you. Walk us through the actual process if we implement where this bill's going, if I'm a patient, as opposed to how it is now, and the option and how that option will be exercised if this bill was passed.
So my understanding is that versus and I'll try to make this as simple as possible, versus the conversation where the provider, the nurse, et cetera, is sitting in a clinic room and talking to a patient and saying, hey, your medication is going to have to come from XYZ pharmacy. We'll let you know whenever it gets here. We don't know when it'll get here, so forth and so on. On the flip side of that, the conversation is going to be patient John Doe. Here are your options of how to get your treatment. Would you prefer to get your treatment from our pharmacy, or would you prefer your treatment to come from an outside pharmacy? It's pretty much as simple as that from a patient care perspective. Where would you, and then weigh out the pros and cons associated with that. There may be situations where a white bagging situation is necessary. I'll give you an example. We're not contracted with every distributor in the country. There are drugs called limited distribution drugs where a manufacturer contracts with a distributor, a McKesson, a Cardinal, etc., a CuraScript. We may not have a contract where we can buy that drug from that particular location. Well, yes, we want to be able to provide that drug to that patient. In that situation, it makes sense for us to use white bagging. Otherwise, we can't get the medication to provide to that patient. In that situation, maybe the patient has to go to another location, potentially out of state, to get that treatment. So white bagging, the point I want to make is to all this is that having the provider involved in the conversation, having the patient involved in the conversation where they can make an informed choice of what works best for this situation is what I think is extremely important. And I'm hoping I'm answering your question that way, just to try to make the process a little bit easier and more streamlined for the patient at the end of the day.
I just think at the end of the day, the process is convoluted and it's complicated. And when you're dealing with something like multiple sclerosis or cancer or something that's serious, the last thing a patient wants to have to do is kind of try to guide their way through such a convoluted and complicated system. And what I'm hearing from you is they're going to be getting advice or direction from the folks who actually would be supplying the drugs in-house.
They're going to be getting advice and direction from the people that are providing their care.
Okay. All right. Thank you.
Thank you, Dr. Summers. Thank you for being here today. Our next presenter is Terry Kirby from the Division of Medicaid, from the pharmacy area, from Division of Medicaid. Terry Kirby, you have the floor.
I also have Cody Smith with me. He's our attorney, so I will defer to him if you present legal questions that I can't answer. I'm Terry Kirby, Medicaid's pharmacy director. I've been a pharmacist for 41 years, and 20 of those years I've been at Medicaid. My background is, prior to that, is independent retail pharmacy and hospital pharmacy.
If you don't mind speaking to the microphone.
I'd like to start by saying that from a public payer perspective, Medicaid is doing things the right way, and it's working. We manage drugs using a clinically sound process while also allowing flexibility to our beneficiaries and Medicaid providers. So what does management of drugs look like for us? In Medicaid, outpatient drugs are covered under two different types of benefits: the medical benefit and the pharmacy benefit or prescription benefit. Drugs billed on the medical benefit are those billed by clinicians practicing in an office setting or outpatient clinic setting. We refer to these drugs as physician or clinician administered drugs. Drugs which are typically dispensed by pharmacists are covered under the pharmacy benefit. For example, let's say you have a terrible lower respiratory tract infection and you go to your physician. They may administer an antibiotic injection such as Rocephin, plus they may write you a prescription for a Medrol dose pack for your wheezing. The physician would bill the Rocephin on a medical claim to Medicaid. Then when you take your prescription for the Medrol dose pack to your local pharmacy, the pharmacist would bill this drug on a pharmacy claim. When we review new drugs to determine which type of benefit is appropriate, we ask, is it appropriate for this drug to only be administered by a healthcare provider in a clinic setting, or would it be a drug for which a prescription would be written for the patient to take to their pharmacy of choice to fill? Now, keeping our decision-making process in mind, it is important to know that there are many drugs which fall into a gray area. That is, they would be appropriate for medical claim billing and in certain situations for pharmacy claim billing. Such an example of a gray area drug could be Remicade. Remicade or infliximab is used to treat a wide variety of inflammatory conditions such as rheumatoid arthritis, Crohn's disease, and psoriatic arthritis. It is administered by intravenous infusion and must be infused slowly over a period of not less than 2 hours. It is typically administered once every 8 weeks. Prior to infusion, pre-medication may be administered at the prescriber's discretion and could include antihistamines, acetaminophen, or corticosteroids. In addition to billing this drug under the medical benefit, we know that some patients may need to receive Remicade at pharmacies which have infusion suites or possibly by a home health nurse in their own home. So for this drug and all others which fall into this gray area, we opened a pharmacy claims billing with prior authorization. If a pharmacist were to bill Remicade on a pharmacy claim, we've designed a message or edit to go back to the pharmacy which states, drugs should be billed on a medical claim, but prior authorization is required if billing on a pharmacy claim is medically necessary to the patient. This ensures the patient has access to this medication if it cannot be billed by the physician's office. Medicaid does not dictate a patient's site of care, and Medicaid's contract with the MCOs states that the MCOs shall not interfere with the patient's right to choose a physician who administers their drugs or their pharmacy or the pharmacy dispensing their prescriptions. In addition, this contract precludes the MCOs from steering beneficiaries to the specialty pharmacies which they own. In summary, Medicaid's coverage of drugs is clinically appropriate while providing flexibility to our providers and to our beneficiaries. Thanks.
All right, are there any questions from the committee? Looks like you're getting off easy.
Thank you.
Yeah.
I like that.
Thanks so much for being here today.
Thank you.
We've got one more presenter before we take our 15-minute break. Mr. Robert Dozer is here from the Independent Pharmacy Association. Mr. Dozer, you have the floor.
Thank you, Mr. Chairman. Members, I'm Robert Dozer, Executive Director for Mississippi Independent Pharmacies Association. Thank you for having me today. The speakers before me have been very truthful with you. Ms. Kirby just said they're doing things right over at Medicaid. I'd like to concur with her statements. Ms. Kirby and her staff do an excellent job in the pharmacy department. Get back to your question, Representative Curry, about what are we doing here? We're trying to give the patient options. We're trying to take care of the patients. These pharmacies that just spoke before me, or pharmacists are some of the most trusted professions in this country. They're healthcare professionals, not the PBMs, not the insurance companies or the managed care companies. The pharmacists are, just like the doctors and the nurses right here. So what we're trying to do is stop these corporate giants from steering these helpless patients to use their specialty in-house pharmacy right here. And that's what it's about. Mr. Deere is a pharmacist, but he also works on the staff of the Board of Pharmacy. One of the Board of Pharmacy's main goals is to protect the public. That's one of his main goals. Then he is also a pharmacist, a trusted healthcare professional. That's what we're doing. We want to give the patients option to where they can choose their health care and how they can choose their health care with this. Now, one reason is the PBMs, insurance companies, managed care companies, they don't want these pharmacies to fill these prescriptions is because of the specialty items. Specialty items are defined in the contracts by these PBMs. Any business out there in these contracts, a lot of these contracts between the businesses, the employer groups, and the PBMs, just like maybe the state of Mississippi as well, state health plan, it gives the ability for the PBM to define what is a specialty item, what is a specialty drug. And a lot of times it is based on price, high dollar medication. They do not want these pharmacies in the state of Mississippi filling these prescriptions. Recently, I read a report. It said 51% of the drug spend is specialty pharmacy items. That's a national trend that's going on right now. So when you start breaking it down, depending on the plan that's out there, or the employer group, or even the state of Mississippi, you're probably going to see 40 to 50% of their total drug spend is going to be based on pharmacy specialty items. Now, here's the real kicker of this. Only about 2% of that population base is using the specialty items. So you've got probably roughly 2 to 5% of the prescriptions that are being filled that's costing 40 to 50% of the total drug spend. That's the real truth right here. Now, what can we remedy? How can we stop all this right here? Because it's a lot of smoke and mirrors. I go back to what Ms. Kirby said. Division of Medicaid here is doing the right thing. They use a reimbursement methodology called NADAC plus 1129. National Drug Acquisition Cost plus an $11.29 dispensing fee. The PBMs, managed care companies, insurance companies, they do not like that reimbursement methodology. It shines transparency. It shows the real truth of what's going on in the drug world today. A lot of people here in this room, across the country, they're hearing about Mark Cuban's cost plus prescription drug plan. NADAC is the pharmacy's cost. That's what it is. And then you add $11.29 dispensing fee. But a lot of these PBMs, they use a reimbursement methodology based off of average wholesale price, AWP. AWP has been shown to be inflated, and it has also gone through a lot of lawsuits over the years. Former Attorney General Jim Hood settled a major AWP lawsuit several years ago when he was in office, probably somewhere around $20-30 million. So it's not only a problem here in the state of Mississippi, it's a problem all across the country. We introduced a piece of legislation this previous session. The PBM side, they really focused on the increase of the dispensing fee. They did not want to talk about the benefits of NADAC. Now that is one of your problems right there, is the PBMs are in total control of the financial aspect of it. AWP drives the price up. NADAC shows you the real cost. Yes, sir.
Let me stop you just for a moment. The gentleman from Jones, Representative Scoggin, has a question.
Yes, sir. Several questions, if you don't mind. Number one, I guess I was confused when we first got started as to what the bill said, because I admit I had not read the bill and I was unsure of where we were going with this and all. But it appears now that what we're trying to do is cut out some of the specialty pharmacies mandating that we use them versus another. Are you familiar with Myers Cocktail?
No, sir.
Okay. It's a vitamin mixture, and I have a patient that has a vitamin deficiency and has to have that once a month. It's an IV injectable solution, and their pharmacy benefit manager requires them to use their specialty pharmacy out of Fort Myers, Florida. They send the medicine every month. But if I need to change or adjust the dosage, as one of the gentlemen said a while ago, it takes a month for me to send that medicine back to get everything done, where the compounding pharmacy in Hattiesburg could make that, send it to me that same day. And so I think the whole idea, if I understand what this whole thing is about, is patient choice. And I'm
Correct.
fixing to make 90% of this side of the room mad, but I agree with Becky 100%. If we got rid of the PBMs and gave Blue Cross didn't require us to go to CVS or Walgreens or whatever and gave us the option to go to wherever we wanted to, then we wouldn't be here having this conversation today.
But that is correct, sir. And the thing is, the PBMs are steering patients. They're steering patients to their retail pharmacies, CVS, Caremark, okay? CVS is the retail pharmacy, Caremark is the PBM. Oh, but guess what? They also own a mail order pharmacy, a specialty pharmacy. So you have all of this vertical integration going on in the PBM world right now, and all they're doing is pushing patients to themselves. And get back to the financial side of it, they're using an outdated benchmark that has been shown to be flawed and gone through a lot of scrutiny in litigation and everything. But I go back one more time, what Ms. Kirby said. They're doing it right over at Medicaid. They're using a NADAC plus methodology.
So the bill that we introduced last year in the House that had that in there, I'm sorry, I don't remember. Did it pass the House? Did it come to the floor?
In 2022, it passed the House.
But it died on the other side.
Yes, sir. And then this year, it died on the Senate side, and Chairman Mims did not bring it up over here this year. He was basically waiting on to see what the Senate would do.
What about with self-insured groups? Let's say, I don't know this to be a fact, but I'm going to say Nissan. I know they have their own pharmacy. If I had to have a specialty medicine, would this still involve them, or are we just talking about just the commercial insurances?
I have not looked at the bill to see, but I think it's including, if I remember correctly off of memory, it's including state employees and all commercial plans.
Okay, thank you.
Yes, sir.
Representative Eubanks.
Thank you, Mr. Chairman. So what we're trying to do is to give more opportunity of choice and access for patients, but what does the sort of macroeconomic climate look like if you go to an all-cost plus? Will that ultimately hurt the patient as far as pricing goes?
No, sir. If you go to a cost plus methodology, like the Division of Medicaid, NADAC plus a dispensing fee, the game will be up for the PBMs, insurance companies, managed care companies, because they will then have to move away from this old, outdated benchmark methodology of AWP, where all the games are being played, and they can manipulate the AWP between the pharmacy and the payer. So it would be beneficial for the business groups out there to go to a NADAC methodology. It's cost cost plus. Everything is transparent under this right here. And that is the big thing about the specialty market right here. The specialty market is the PBM's cash cow. And they knew if we went to a NADAC plus methodology, we would really be hitting their cash cow.
Will that hurt the independent pharmacists? Will they not be able to get volume discount and all of that?
You're talking about if we go to a NADAC plus methodology?
Yeah.
No, sir. No, sir. We were the ones that introduced the legislation to move to this methodology.
Thank you.
Right now, the AWP methodology, AWP is supposed to stand for, average wholesale price, but really it's what's always profitable for the PBM. That's what it's about.
All right.
Always what's profitable,
We're going to stop right here and take a break for 15 minutes. Let's be back in here at 3 o'clock. And at 3 o'clock, we will hear from Mr. Sean Dixon, from the Senior Vice President from the Pharmaceutical Policy and Strategy.
their spending on prescription drugs, about 22 cents of every dollar. With all 19.9 is on hospital costs, and a lot of that is becoming the services associated with providing drugs, right? When we administer drugs in a hospital setting for cancer or something like that, rather than in a doctor's office, the cost is much higher, and that's being passed on to employers and being passed into our premiums. And so what we've done is done some analysis at the national level and then at the Mississippi specific level about what some of those costs are and how much savings are achieved by trying to pay for the drug addict's actual cost rather than the inflated price. Now, we have lost my screen apparently.
Well, we still see your screen.
You can't? Okay, for some reason, I'm having some trouble here. There we go. Okay, so we've already talked about what these drugs are. I'm not going to spend any time on this because you're already well familiar with this, but it's important to note that these are extremely expensive and a significant cost as we spend more and more on drugs over time. And we'll note that final concern there, right? That when we have providers, hospitals in particular, buying drugs themselves and then billing for them at whatever rate, they have limited incentives to try and either choose a lower cost option or reflect the actual cost of that drug and what they're charging the insurance company and ultimately all of us through our premiums. So what happens is we see really, really high markups on these costs relative to what they would cost if they were purchased through a pharmacy. So at the national level, this is a study of claims data from 2019 to 2021 looking at 10 drugs that are frequently eligible to be dispensed through specialty pharmacy as well as through hospitals. We find that overall, hospitals are charging about twice as much as that drug would cost through a specialty pharmacy, which is significantly more than what a physician office. An independent physician office is only charging about a 23% premium on the cost of that drug. So when we go through a hospital, that means every time one of these 10 drugs is administered, it's costing over $8,000 more than it would have if it were acquired through a pharmacy. And again, all of those are costs that are being passed into premiums and being passed along to employers. Now, this isn't just industry-sponsored research. We've got 3 key peer-reviewed studies in the Journal of the American Medical Association that found the exact same things. That the markups that hospitals are charging have doubled in a 5-year period relative to what Medicare had to pay for the same drug. And some of these markups get to over 600% more than the hospital actually paid to acquire that drug. And then the median of these prices, not even a median, it's sort of a median right in the middle, is going up to 300% of what the drugs actually cost relative to what Medicare is paying. And so that's really important, right? If we're going to look at this next slide, just Mississippi-specific data, and please step in with any questions if you have them. We did a limited analysis based on the data that was available, looking at what drugs cost in Mississippi when they're billed through to the hospital versus what Medicare pays for that same drug. And as we've heard, Medicare and Medicaid are trying to pay based on what the actual cost of the drug is and not provide a markup to it. And so they use something called average sales price, and they use a 6% fee on top of it to make sure that the provider has enough money to handle that drug. And so what we were seeing on 5 of these drugs was in the claims data in Mississippi that providers were charging twice, hospitals were charging twice as much for private insurance as they were charging the Medicare program. That's a significant markup, and that is all being passed into our premiums and being passed along to employers who are then being paid lower wages because of it. And that turns out to be about $4,500 per drug infusion, more than was being charged for private insurance than was being charged to the Medicare program. And this is less than $8,000 we saw on the previous slide at the national level, so the problem isn't quite as bad, but we're still seeing that same trend of buying the drug and then charging significantly more for it. We've got some examples about specific drugs here, right? Remdesivir, which has been mentioned before, almost 3 times as much as Medicare is being charged. And another drug, Tecentriq, a cancer drug, charging over twice, 133% more than Medicare. I just want to talk about why this happens for a moment here. Again, please, I can't see all of you, just, step in with any questions. One of the reasons for this is that we don't have a particular amount of competition in the hospital sector because of these network adequacy requirements that insurers are required to meet. Right? You have a geographic area for your insurance plan, and you have to have a certain number of hospitals and infusion centers and the like in it to meet standards. And so that means that there's only one hospital or one big health system that owns multiple hospitals and multiple providers' offices. They can basically dictate their charges. So we see that happening in the charges they actually have for provider services, and maybe those are warranted, maybe their doctors are worth significantly more. But this drug doesn't have any more value just because it's being put through a hospital system. They should be able to charge this markup on top of the drug itself. And so that's one of the really big challenges here is that you're not able to negotiate lower rates for the provision of these drugs with hospitals and provider offices because there's a requirement that you cover services at those hospitals and providers to meet these network adequacy requirements in the geographic area. And so what white bagging is really a response to is a way to try and control costs, often at the pressure of employers, to bring down the specialty drug spend. I think it was mentioned earlier that specialty drugs are about 50% of our spend, even though it's only on a handful of patients. Well, one of the problems here is that those specialty drugs, when they're being administered in hospitals or hospital-based infusion centers, the hospital's charging twice the cost of the drug to the private insurance company versus what they acquired it at. And that's really the problem that white bagging is trying to solve. It's trying to say, let's actually pay for that drug what that drug costs in a pharmacy and deliver it to the provider. And so anything that takes away the ability to do that or gives more power to hospitals and provider offices to charge exorbitant rates for a drug that doesn't cost any more just because they bought it is really sort of what's driving the problem here. Are there any questions about this data?
Sean, this is Lee Yancey. So if there were a set rate that the particular drugs cost, whether they're bought at an outside pharmacy or they're bought at a hospital, if there were a set rate and it could only be reimbursed at that rate, then I guess the patient, the patient would just have the benefit of getting a drug where it was most convenient for them and where it was the safe, provided to them in the most safe manner, had been stored in a safe manner, that there was no additional waste. If we took the different pricing equation out of it, and I think this bill prevents there from being any additional fees or any additional co-pays from being charged, but I don't know that it addresses the actual pricing of the drug itself. I guess the question I'm asking is if somehow we we're able to maybe set the pricing or fix it to a certain index that was maybe a moving index or a national average index, would that benefit the consumer?
Well, obviously the devil's going to be in the details of something like that, but I think in the past, one of the things we've looked at is the ability to have the same payment rate from the insurer to pay the hospital or the provider's office the same amount that they would have paid that specialty pharmacy for the drug. So, right, saying this is the rate that a pharmacy is going to pay for this drug, we're going to pay you the same rate that we would have paid had we done a specialty pharmacy. I think something that's been proposed in the past. Again, we have to sort of make sure that we're not building in incentives to choose higher cost drugs, to try and acquire drugs at higher rates that you sort of are able to work them up a little bit more. But, the idea here is not that white bagging is necessarily a desired solution. It's a response to extreme costs.
All right, does anyone have any questions? Representative Curry? Lady from Lincoln?
Thank you. I guess I missed who he is with.
So he is with the America's Health Insurance Plans.
Okay.
He's the Senior Vice President of Pharmaceutical Policy and Strategy with America's Health Insurance Plans.
Okay, I'm not sure what that is, but what I'd like to ask, isn't it this kind of same thing when you go to the hospital and you look on your bill and you got, you took 2 Tylenol for fever and you could have bought like 10 bottles of Tylenol for what they charged you? Are we not talking about the same thing?
That's exactly the same thing. It's just this is being done on drugs that are infused or injected as opposed to that Tylenol that you saw.
I'm good.
All right. Any other questions?
All right, well, thank you.
Yeah, thank you so much for being with us today. I appreciate it.
Yeah, so just a few more comments here. So, right, as we talk about exactly sort of what white bagging and brown bagging are, but I think what's important to recognize is that all the pharmacies that are shipping these drugs are licensed and are held to regulatory standards, right? The health insurer has no interest in paying for a drug that is going to show up and be useless, that's going to have missed its temperature window, that is not the right dose for the patient. the drug again. So they are looking to really bring down costs and find effective solutions. It's also important to recognize that there are a lot of situations where specialty pharmacy delivery or direct delivery of a patient-specific dose is the standard of care. In a lot of radio pharmacies that's being done for oncology, right, the preparation actually has to be manufactured at the patient-specific dosing level given their weight and their condition by drug manufacturer and routed through the specialty pharmacies for the infusion itself. So we already have these standards in the market for how to safely deliver drug, and it's in the best interest of the payer to make sure that happens, because otherwise they're the one who's going to be bearing that cost. So again, as we this, I think it's become sort of clear through this presentation, but again, we have significant hospital markups on these drugs, 2-3 times as much as the actual acquisition cost of it. That's going to be driving up costs for patients overall. Whether it's driving up the cost of that individual patient is going to be very dependent upon the structure of their insurance benefit that's available for their insurer and how much they net their out-of-pocket during the year versus on their medical or their pharmacy. But it's driving up the costs to the system. It's driving up our premium costs for everyone, particularly for employers. And those small employers where you have one patient is extremely expensive, you don't want to be paying 2 or 3 times the cost of that actual drug if you can pay a lower amount that is actually reflecting the acquisition cost. So I think it's just really important to recognize that the patient safety issues are really consistent with our existing supply chain standards, especially pharmacy standards. And what we really need to be focusing on is the financial toxicity that can come from these high costs. States across the country are considering this, but what they're really trying to stay away from is policies that would lock in higher costs by taking away negotiating leverage. We saw in Indiana a study of the amount of savings that came from sort of direct pharmacy delivery of drugs by taking out the ability to overcharge relative to what the drug costs. You can see what those savings are here. We've heard that there are challenges. All systems and changes will have challenges. Medication issues can happen within a hospital itself. But overall, the idea here is that we shouldn't be driving up financial toxicity to the system just by marking up the price of these drugs. And what that is really in response to those excessive markups. I thank you for your time and happy to answer any additional questions.
All right, any other questions? All right, thank you, Mr. Dixon. Thank you very much. Our next presenter is Mr. Michael Power. Mr. Power is the Pharmaceutical Care Management Association of America. Delighted to have you here. You have the floor.
All right. Actually, that is on. I can tell. I was about to ask. Mr. Chairman, members of the committee, thank you for the opportunity to be here today. As Chairman Yancey said, my name is Michael Power, and I'm with the Pharmaceutical Care Management Association. We are the national trade group that represents PBMs. We have close to 20 PBMs within our membership, but it is important to note that there's about 70 not full service, but there are 70 PBMs that operate in this country. As I think Mr. Dozier noted earlier, Mark Cuban has recently gotten into the PBM space as well as Amazon. Unfortunately, Mark Cuban's PBM has gone from cost plus to cost plus plus because he's finding it's more expensive to run this business than initially thought. Oh, sorry. Try to get a little closer. Is that better? All right. Sorry, the cord is like, well, maybe that works. There we go. All right, now we're in business. So our invitation here today was to talk about white bagging, and that's where I planned on focusing my comments. And I think we've heard from numerous speakers today on the definition of brown bagging, white bagging, and clear bagging. So I'm not going to go down that road to try to further confuse the message. I think we did a pretty good job of clearing those up at one point, so I'll leave it there. But what is important to note, and I think one part that we didn't talk about in this conversation, is to use white bagging, to not use white bagging, to use a PBM-owned or affiliated specialty pharmacy is the choice of the plan sponsor. So in the case of this legislation here, I think it focuses on the state health benefit plan, Medicaid, and also maybe the employee retirement plan, I think was the three entities that were listed. And so today, those plans in the state could choose to restrict the use of white bagging, or they could choose to restrict the use of a PBM-owned or affiliated specialty pharmacy. But the reason they do make that choice, and I think Sean did a nice job highlighting a lot of these numbers, is that when you look at using a hospital pharmacy for some of these chronic conditions, the cost to dispense these drugs is very significant. And to Rep. Curry's point about, the Tylenol, It should cost you 10 cents probably, but it sometimes costs you $10. And we're seeing that a lot in the specialty drug space. We're seeing drugs that cost well beyond even their list price. CMS recently did a report, and that's some of the data that Sean referenced earlier on the multiplier effect of the cost charged by hospitals when dispensing drugs. But that was a report that came from the Centers for Medicaid and Medicare Services. That wasn't us. I think pharma even has some research indicating that many of the drugs that their companies manufacture, the list price sometimes is often inflated when sold from a hospital pharmacy. So it's important to remember the cost associated with these decisions and these plans. I don't know how many of you are familiar with the iron triangle in healthcare, but obviously, you got to consider cost, quality, and access. And so that's what a lot of these plan sponsors look at when they're designing their benefit. And so many times they use white bagging as a way to provide quality and access to their covered lives and to ensure sort of some cost controls. To your question, Chairman Yancey, about language in the bill that would restrict hospitals or other locations from charging a different rate, we would support that approach. Obviously the devil is in the details. We've seen some states look at language that would basically say that the hospitals would have to agree to rates and terms rates and reimbursements so that they could not charge a rate that they just seem fit, because at the end of the day, that cost will be borne by someone. Your legislation does, I think, restrict how those costs can be borne. But so, if your legislation were to pass as written, it would apply to the health plan, the plan sponsor, the person paying for the benefit. I'll kind of pause there for a second. One other thing I will mention, one of the presenters talked about the safety and the delivery of drugs. This is URAC. They're a third-party entity. They're not us. They come out with a report on specialty pharmacy dispensing and delivery. Dispensing accuracy is 99.98%. So that's the medication actually being put in the volume or in the package is dispensed at a rate of 99.98% accurate, and then the delivery is 99.96%. So while that is not perfect, it's also not a large issue that is occurring frequently when you think about the volume of prescriptions filled and you think about the number of lives covered. One last thing I'll touch on, because it was brought up that I think is outside of what we were focusing on here today, but was the NADAC Plus dispensing fee. I think it is important to note that Medicaid and the state chose to go to the NADAC Plus dispensing fee formula, which was an increase from dispensing fees usually around $1.50 to $2 to $11.49. And the state, I think, appropriated money to budget for that increase and to pay that new dispensing fee. Last year, the legislation contemplated putting that proposal on self-insured broader commercial marketplace, and the employers, there were a number of employers that came to the committee and spoke up, stating the cost that they would face if that legislation was in fact passed. I'll sort of pause there. I'm happy to take any questions if there are any.
During the break, I think I learned, I'm always skeptical of what I think I learned, that specialty drugs, which make up over 51% of prescriptions, is that right? Are not included in the NADAC price, is that correct?
That's a great point. Sorry, I forgot to mention that. So NADAC is a survey, and had I known this was going to come up in today's meeting, I would have looked this up to get a more recent number, but I think 30% on average of pharmacies, 35% of pharmacies in this country respond to that survey, and specialty drugs are not included in that survey.
So how would placing the NADAC plus 1129 or whatever, and how would that work if the specialty drugs were not also tied to the NADAC, or how would you tie them to the NADAC when they weren't even considered in the NADAC indexing?
So I think when some states have debated this, they've contemplated tying it back to the average wholesale price of the drug, but that's the model today. So it's if you've got to go out of your way to tie other drugs to it, why not just keep all drugs and keep it consistent?
All right. Any members of the committee have any questions? All right.
Who sets the dispensing fee?
On the Like on a commercial plan, or?
NADAC 1129, who came up with the 1129?
I'd have to go back and look at that, but I think it was, I think state Medicaid agencies, because they differ around the country. And Tennessee even has like a range of dispensing fees, depending on the type of medication and treatment.
Representative Felcher.
Yes, sir. How many states operate under more the model that Mississippi is currently operating under? And how many states operate under more the model that would put us conforming with the proposed legislation?
As it relates to white bagging?
Yeah.
I think 5 states have passed legislation to date that sort of follow the proposal here. And several do put that pricing restriction language in there as well.
What have been the effects of those 5 states to the patients? Have we seen a cost savings to the patient, a cost increase?
As of right now, it's too early to tell. Most of these laws are 2 years old, and some haven't even been fully implemented. And many times contracts are multi-year, and so we haven't truly seen the full impacts of these costs on these.
Any feedback at all on from the 5 states, from your industry?
I haven't received any feedback from the states on how it's operating from any of their departments of insurance or anything like that. No, sir.
That's interesting. Thank you.
All right, I don't see any other questions. I want to thank you all for participating today. I think that we have received illumination on this issue, and we will have time to digest what we've learned today. And we'll be thinking about this as we get closer to the 2024 session. But again, these issues are going to continue to be placed in front of the drug policy and the public health and the insurance committees regarding pharmacy and insurance and PBMs and pricing and drugs. So this is not going away. And while it's complicated, all these things are related. They're similar. They're not exactly alike, but they're all in the same family. And so the more we can become educated on these issues, the better prepared we'll be to pass good legislation. So again, I thank you for your participation today, and we are dismissed.